Thank you, Bill, for letting us know. Good morning, everyone. We're glad to have you join us this morning um, for our 8th episode of Let's Talk About OMM Research. I'm Jane Johnson, and I am the Associate Director with DO-Touch.NET. Before we begin, let's take a moment for the housekeeping rules of the webinar. We've had some requests that participants would like to know who else is out there. And so with the webinar format, we don't have a way to share that. So if you would please add your name and location into the chat to all panelists and attendees, then everyone can see who else is attending the webinar. If you have registered for CME credit, then you must add your name in the chat to verify your attendance in order to receive CME credit. Additionally, you will need to complete the physician attestation form, which a link was emailed to you this morning. And you'll need to complete the evaluation survey, which a link will be emailed to you either this afternoon or Monday morning. And just so you know, the Let's Talk About O&M Research Planning Committee has no conflicts of interest to disclose. And if you have technical issues during the webinar, please send a message to all panelists in the chat. And if you have questions or comments during the presentation, please feel free to type them into the Q&A pod. Also, please feel free to address each other's questions and comments there as well. After the presentation, we'll have time for discussion and questions. If you would like to speak during the discussion, then please just raise your hand and we will unmute your microphone. We ask that you briefly introduce yourself. Please feel free to turn on your camera if you'd like, so we can see who you are. When contributing to the discussion, please limit microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. After everyone has had the opportunity to make comments or ask questions, there may be additional time for comments or questions. Please keep in mind that this webinar recording will be placed on the DO-Touch.NET website, where you will have the opportunity to continue the discussion. Watch for an email from DO-Touch.NET announcing when the recording and discussion forum are available. Now, please help us welcome Dr. Dawn Altman. Dr. Altman is the Dean of the College of Graduate Health Studies at A.T. Still University. Dr. Altman has served as president of the Arizona Public Health Association and president of the American Board of Dental Public Health. He has volunteered with Health Volunteers Overseas and has been a member of the National Disaster Medical Service for the past 19 years. He was deployed to New York City after the 9/11 attack and also worked the Grand Princess quarantine operation at Miramar Marine Air Station. Dr. Altman's research interests are currently centered on public health and higher education. He has published articles in Public Health Reports, the Journal of Dental Education, Journal of the American Dental Association, Journal of Public Health Dentistry, and World Medical and Health Policy. So I have a presentation from Dr. Altman, and I will pull that up here so we can oops, sorry, apparently we apparently I need a passcode to pull up the recording. Let's see if I can find that.
I'm not seeing that in the information I have, Jane.
I apologize. Dr. Altman, do you happen to have?
You know what, Jane, I don't have a passcode either, but I have the presentation. Do you want me just to share my screen?
That would be lovely. I apologize. Thank you so much.
Do I have the rights to do so?
I believe so. Let me make sure. Yes, you do.
Hello, everyone. It's good to be with you today. Bear with me for just a few seconds. I'm going to start. The consequences of COVID-19. It seems that the more we learn about COVID-19, the more there is to learn. I want to just briefly start with what we know about it. That is actually less than 1/7 of the world population, and missing about 27 countries altogether. And you all know these numbers have continued to increase since May 12th. Very briefly, let's take a look at the signs and symptoms of coronavirus disease. These are symptoms that may appear 2 to 14 days after exposure. Over the past 15 months, we have recognized the following common signs and symptoms.
Don, we're having troubles with the audio.
Well, this just goes on. The longer the pandemic continues, no surprise that about half of the COVID survivors are worse all over the world. Many of the symptoms on the last slide causing problems to the various systems. Acute COVID-19 is causing heart problems, kidney damage, liver problem and damage, brain and neurological issues, and of course, lung problems. The symptoms I've presented have been symptoms that were reported to the healthcare worker in the hospital, urgent care center, or physician's office. Sorry, folks. I'm going to reshare and see if I can fix the audio.
Thank you.
Oh, now it is asking for a passcode. Which I don't
This
have.
is going to be one of those days, isn't it?
I don't have a passcode either, and it won't let me share sound unless I have a passcode.
Are you perhaps able to just share the presentation
What do you mean?
and give us the audio live?
Oh. Hold on, let me just see if I can. Hello, everyone. It's good to be with you today. If you bear with me for just a few seconds, I'm going to open the mouth into common signs and symptoms. So am I sharing my screen right now?
Not yet.
It says I'm sharing the screen.
Yeah, I believe you are.
Well, we just see a camera, no slide or anything. Okay, we can see the slide now.
And other symptoms. So a lot of symptoms going on. And you can see here that the list just doesn't seem to stop. The list just goes on and on and on. The longer the pandemic continues, the more symptoms we seem to discover. And no surprise, but about half of the COVID survivors reported a worsened quality of life. Any better? Many of the symptoms on the last three slides are causing problems to the various systems in the body. Acute COVID-19 is causing heart problems, kidney damage, liver problem and damage, brain and neurological issues, and of course, lung problems. The symptoms I've presented have been symptoms that are reported to the healthcare worker in the hospital, urgent care center, or physician's office. I would be remiss if I did not point out to you that there are manifestations in the mouth from COVID-19. These are just 12 of them. None of these symptoms are only seen in COVID-19 patients, but patients who never had these symptoms are now having them since the onset of their COVID disease. Here are some suggested dental diagnoses. I bring these dental issues up because it's well past time to reconnect the mouth to the rest of the body. So much can be found when looking in a patient's mouth. There are so many connections with systemic diseases. A current study from the National Institutes of Health and the University of North Carolina at Chapel Hill discovered that the mouth is a route of infection and an incubator for the virus. For patients with mild or asymptomatic COVID-19, cells that shed from the mouth into saliva were found to contain the RNA from SARS-CoV-2 and the entry proteins, indicating infected oral tissues that appear to be a source of the virus in saliva. We also know that there are many comorbidities that increase the risk of here are some. Yeah, it seems that if we use we know that there are variants. Previously, it's not surprising that variants that are over 1%, but there are over 200 variants. What we have seen so far more. This may change in the future. Just saying, in theory,
I think we've lost the audio again. I'm sorry about that.
Still no audio?
No.
We had it for a while, and now it's gone. And yeah, I can barely hear it.
What this means is that new patients participation anyone that's been this group of prepositions and speakers. Let's move on to provision. Sometimes confuse matters. Sometimes
So Jane, do you think maybe what we can do is open up just some conversation, some discussion to give Don a little time to see if there's any other alternatives? Don, what do you recommend us to do?
Can you hear me okay right now?
Perfectly.
Yep.
Okay, this isn't going to go. I'm going to stop sharing and go back to this one. Here we go. Bear with me here. I'm going to get this back up to speed. Okay. Sorry, give me just a few minutes. If you guys want to go on with some of the business, I'm going to pull up the PowerPoint and I'll just do it live.
Okay, that sounds great. So just a few questions. Maybe we can just open up for a little conversation. How many people have seen cases of post-COVID syndrome in their practices?
I see 3 hands raised.
Okay, do you want to give them the mic to see if they?
Oh, there's even more. Does anyone want to make a comment about that?
About how many or how severe of symptoms are you seeing?
How about Dan Bensky? I have allowed you to talk if you want to make a comment.
Dan, you're muted right now.
Oh, he'd prefer to chat. No problem.
Okay.
So Almut says she has had 1 patient. How about you, Amy? Okay, Dan says he's had a couple of patients.
How many treatments have you all been giving to these patients?
A dozen, yes.
Okay, thank you, Dan.
Yeah, so Dan says he's seen a couple dozen of these patients, with the primary issues being fluid issues in different tissues. Amy Dean says she's seen a half a dozen in the hospital post-COVID. How about you, Bill? You have your hand up. Do you want to talk or? Oh, okay. So, Bill Devine says his 9 patients, him and other with residents seeing patients in Arizona. Jed Downs has seen 3 or 4. They've all had adhesions of the pleura and mediastinum.
Steinem?
Okay, thank you. Obviously, I'm not a doctor. I've not dealt with anyone who has CNS issues as their primary complaint. I see them post-infection in the office. Okay. So Bill Brooks says he would like to talk, and then also Bill Devine. So we'll start with Bill Brooks. There you go, Bill. You'll have to unmute yourself.
I've seen one patient in particular. Can you hear me?
Yes.
Who had long hauler syndrome. And she's had a variety of what would otherwise be classified as rheumatologic signs and symptoms. I also just serendipitously was talking with someone who's not officially my patient, and he developed hand arthritis, but has a history of psoriasis. So it looks like either that was a primary complication of COVID or his psoriatic arthritis was uncovered. His hands were diffusely warm, swollen, tender. The patient I've actually been caring for is a woman in her 60s, I think, who had COVID early in the epidemic. She had posterior scleritis, was treated with prednisone, had a lot of other symptoms that she was attributing to the prednisone, had a rheumatologic workup. They didn't find anything. And then during my care of her, she developed warm, swollen, diffusely tender hands and wrists and ankles. And we elected to just watch it. And those subsided over several weeks. So I don't really know what the diagnosis of that might have been. Bottom line is she's feeling better. So whether, again, it was a brief uncovering of an underlying rheumatologic problem or a primary complication, I don't know. So limited experience, but I've seen some.
I think we're ready. Can you hear me?
Yes, we can.
Okay, so sorry, I don't really know what happened, but I'm gonna not take up a whole lot more time, but I want to walk through what, starting with the post-acute COVID-19 syndrome. I think part of the confusion is just even what we call it. You can see there's like 6 names there that are commonly used in post-acute COVID-19 syndrome. For the rest of this presentation, I'm going to refer to those folks that have the symptoms, post-COVID-19 syndrome, as long haulers, okay? But I think most of you know what that is. They're finding that this is young and old people. It really doesn't seem to discriminate. I think one of the lessons that we can learn is from the survivors of MERS and SARS. Both coronaviruses, and both had their own long haulers. And I'll talk about that in just a few minutes here. There's no widely accepted definitions of the stages of COVID-19 recovery, but pretty much the medical community is pretty much agreed on these 3. The acute is up to 4 weeks, the ongoing symptoms from 4 to 12, And then the post-COVID symptoms, anything greater than 12 weeks. And keep in mind that these stages reflect symptomatic recovery. They're not related to active viral infection and infectivity. So the most commonly reported long-term symptoms, ones we're all familiar with. Other reported long-term symptoms, that really this list is going to go on and on. Look, nope, sorry. Okay, this is the last one, I guess. I think what you notice, even though you couldn't hear me before, in the acute phase, pretty much everything that you find in the acute phase could be a symptom in the post-acute syndrome. There were some studies related to a headache that showed that migraine-like headaches lasted over 6 months in about 38% of the participants in the study. Go down to hair loss. One study showed that 20% of the participants had hair loss, but it did resolve around 6 months. And loss of taste or smell. One study reported that 1/10 of their study population lost taste or smell for up to 6 months. Real briefly, some selected research. A study in Sweden of 323 female healthcare workers with an average age of 43 reported 1 in 10 had mild symptoms. Still, at least one moderate to severe symptom 8 months later. Most commonly, it was loss of taste and smell, fatigue, and respiratory issues. Johns Hopkins has started a long hauler study that they hope will eventually contain 25,000 people. They found so far that most long haulers had mild to moderate symptoms and were not hospitalized. And they also estimate that between 10 to 30% reported prolonged symptoms. So that 10 to 30% is what we've found in a lot of the research for folks that got acute COVID. 10 to 30%, anywhere from 10 to 30% go on to be long haulers. In a study from China, it included about 1,700 patients that had been previously hospitalized in Wuhan, China. At 6 months, the majority continued to experience one or more symptoms. Fatigue or muscle weakness was about 63%, sleep difficulties 26%, and anxiety or depression about 23%. And the study from Germany consisted of 100 patients who had recently recovered from COVID-19, and their MRIs performed a median of 71 days after diagnosis revealed cardiac involvement in 78% of the patients and ongoing myocardial inflammation in 60%. This is, I think, was a very interesting study that was published in Nature magazine using smartphones for reporting symptoms. Study was conducted from March 24th through September 2nd, 2020. There were about 4.2 million app users who reported symptoms, and most of these were mainly the UK. It ended up focusing on 4,182 users who were consistent and confirmed cases. While most of the people who developed COVID-19 were back to normal in less than 2 weeks, the data suggested that 1 in 20 people with COVID-19 are likely to suffer symptoms of ongoing COVID that persist for 8 weeks or more. About 1 in 50 people continue to have symptoms for 12 weeks or more. So that really suggests that post-acute COVID could potentially affect many hundreds of thousands of people in the UK alone and millions worldwide. Most likely to develop post-acute COVID were older people, women, and especially those who experienced 5 or more symptoms. The nature and order of symptoms, which included fatigue, headache, shortness of breath, and loss of smell, didn't matter. People with asthma were more likely to develop long-lasting symptoms, although the study found no clear links to any other pre-existing health conditions. So using this information, the researchers developed a model to predict which individuals were most likely to develop post-acute COVID. Remarkably, this simple algorithm based on age, gender, and number of early symptoms accurately predicted almost 70% of the cases of post-acute COVID. It was also about 70% effective in avoiding false alarms. The team also validated the algorithm's predictive ability and data from an independent group of about 2,400 people, and which with confirmed COVID and a range of symptoms. And this group, having more than 5 symptoms within the first week, also proved to be the strongest predictor of post-acute COVID. And again, the model worked quite well in identifying those most likely to develop post-acute COVID. I think one of the things you can notice is no matter which study you go to, you often get conflicting data. You know, this percentage or that percentage, or a different order of symptoms. So there's a lot of studies out there, and clearly they're coming every day. I think if you're on any sort of news feed, you probably see a new study or article about long COVID. I think it's also important to understand that there are some grassroots efforts led by people with post-COVID syndrome that have formed so as to provide support to long haulers and to help find answers to their questions. Most of these social media sites require that you have post-acute COVID syndrome to join. The NIH has referred to them as citizen scientists. And these are just four of the groups. I actually will mention in just a second here something that the Survivor Corps actually has posted. So, okay, so what, if anything, have we learned from SARS and MERS? I'm not going to go into all of the physiological issues that we're finding, but immunological issues are huge. I think one of the things, autoimmune, there was quite a bit in the literature, but not as much as there was related to respiratory problems. And I think, you know, we all know that the lungs are a big part of what's getting seriously injured in long haulers, and well, actually even in the acute COVID patients. There's quite a few cardiovascular problems they're finding, anywhere from 8 to 12% actually of the patients that have been studied have some sort of long-term cardiovascular problem. And they found that the same in SARS and MERS. There was a study done on 25 SARS survivors. 40% of them continued to have cardiovascular abnormalities at 12-year follow-up. So some of this damage is not going away. Many studies have published on the neurological impact of COVID-19. Mainly that is olfactory and gustatory dysfunction. Olfactory dysfunction is probably the most, that's over 50%. Gustatory is close to about 44%. Mental health, I think that's an area that's hugely important. Clearly, when you're in the whole mind, body, spirit realm, lots of studies about the mental effects of long COVID. And I don't think there's anything that you would be surprised about from a symptomatic point of view: depression, PTSD, anxiety, those kind of things. And again, those were also found in SARS and MERS long haulers. But there does seem to be some sort of concern about some brain damage as well that's causing some of these mental health problems. The last one here, gastrointestinal, hepatic, renal, and dermatological. There have been a few studies, and most of those studies were not with very many participants. But none of these three really seem to be very prevalent in the long haulers, though they seem to be in the acute. The percentages that they're seeing in some of this stuff is not great, anywhere from around 15%. But that doesn't mean of course you're not going to see it. You will see it. So you guys are physicians. I don't need to explain a lot of what I actually had recorded here, but there does seem to be a lot about excess inflammation, particularly as it relates to the heart, which of course causes shortness of breath, chest pain, and elevated heart rate with exertion. And the inflammation apparently in the studies that I read affected people regardless of their pre-existing conditions or how sick they were when they initially had the virus. The autoimmune response, There's thoughts that it might trigger immune response to the immune system to mistakenly target their healthy body's tissue instead of the virus. Lupus and rheumatoid arthritis commonly cause fatigue and digestive issues. And those are two typical post-COVID-19 symptoms. Problems with the nervous system, dysautonomia, which refers to the dysregulation of the autonomic nervous system, seems to be a problem. It affects the blood flow, which can cause fatigue, headaches, brain fog, and exercise intolerance. Blood clots and blood vessel damages, this seems to be actually pretty common as well. When the lining of the blood vessels become no longer smooth, cells kind of lining the vessels gets damaged, they get sticky, and then of course blood clots form. Those blood clots form in the lungs, which of course cause shortness of breath, in the brain, which causes brain fog, and heart can cause palpitations. So how do we handle the post-COVID patient? Communication, we've got to do a better communication between agency organizations, governments, and health research scientists. Policy, it's important for policymakers to develop a comprehensive strategy in providing resources and capacity and caring for COVID-19 survivors. Coordination, hugely important, and I think is getting more attention. Really dedicated interdisciplinary outpatient COVID-19 recovery clinics and clinic protocols that would include comprehensive physical, cognitive, and psychological assessment. You know, I think it seems so like you wouldn't have to say it, but you know, this is really a multi-system syndrome, and it just does require a multifaceted approach. And there are comprehensive clinics out there. I know Johns Hopkins was one of those that actually started early on with their own COVID-19 recovery clinic. Oh, research. Clearly we need more research, and I say that a little bit tongue-in-cheek because it seems like there's just thousands and thousands of articles coming out just almost every day, it seems like. But we still need some really long-term, large studies done. You're really using some big data, so really using administrative record databases that are already out there. A lot of the studies that I read were really, 26 people or 100 people. And so I think we need to do more. The last one, vaccinations. And that patient advocacy group that I mentioned, this Survivor Corps, they did a survey, they conducted an informal survey of 450 people with post-acute COVID and found that 171 people said their condition improved after they got their vaccination. And a recent UK study followed 66 hospitalized COVID-19 patients who had symptoms that lingered for 8 months. And 44 were vaccinated and 22 were not. And about 23% of the vaccinated patients reported that their symptoms improved compared to around 15% of unvaccinated people. Also, fewer of the vaccinated people saw a worsening of their symptoms. So clearly, this is self-reported. There's a lot of bias here. There's a lot of issues related to, what one's mind, the placebo effect. But I think it does warrant more research into whether or not vaccinations are really helping long haulers or not. So how can we respond better? Got a list there. I mean, there's, all of us in various fields. We really need to come together to help fight these infectious diseases. We need to involve local communities in disease education and surveillance. We need to train local workers to safely address infectious diseases. We need to increase the ability of local laboratories to detect and report infectious diseases. We need to budget money to deal with outbreaks locally and globally. We need to create networks that share information on infectious diseases and outbreaks. We need to make emergency plans to quickly redirect trained people and supplies to outbreak areas. And we need to declare a state of emergency during the early stages of the outbreak. As you know, we didn't do that very well this time around. And I think, unfortunately, politics got in the way of really taking it quite seriously in the very beginning. And And if I could quit sharing, I would do that. All right. So sorry about the whole first 15 or 20 minutes you probably didn't hear. I don't have a very strong voice, so it probably doesn't sound much different than what you were hearing. But you know, it was a very interesting search for some real answers related to what was going on with long haulers. And most of the articles would always say, but we don't really know what's going on. They said that as it related to everything from, you know, how it affected the system or why it affected the system. So I'm happy to entertain any questions that perhaps I can answer. Time sequence, a time sequence. So the question is there a time sequence for the onset of post-COVID symptoms? So for what we call post-COVID, it's 12 weeks. So otherwise they're just continuing COVID. There does seem to be, some people say that, you know, the following order, they come in fatigue, chronic, this was in the beginning part, muscle pain, but really in real life, that's not what everybody is seeing. So just because somebody doesn't show up with fatigue or fever or muscle aches, and because many times they just show up with COVID toes, or they show up with loss of taste or smell. So really that phrase that I put in there about theory and practice would be the same, but in practice, they're not. Anybody that does research knows that, or anybody that's actually seeing patients daily knows that every patient's going to be different. We just have some generalized what's first. But after 12 weeks is what almost all of the literature really considers post-acute COVID-19 syndrome as 12 weeks or greater. And clearly, you know, we haven't had it very long, so we don't know if they're going to have 12 years of symptoms like they did in the SARS outbreak.
Yeah, Brian.
So Don, in my research, there was indication that people that didn't even have acute symptoms of COVID could come down with the long haulers problem. So what did you see along that line regarding prevalence of that?
Yeah, so that was mentioned in many articles, actually, that there were people that had no symptoms and then all of a sudden, you know, 12 weeks later, they were sick. If I'm going to aggregate all of the research that I did, it still comes down to that 10 to 30%. So if they had COVID, regardless of symptoms or whether or not they were severe, about 10 to 30% of those people. There was one study that was like 42%, but it seemed to be a real outlier. But 10 to 30% regardless, symptoms, asymptomatic, severe, 10 to 30% that were diagnosed as COVID, could be a long hauler.
From previously in the chat, Amy Dean had posed a question: is that like a reactive arthritis? I wonder.
I think that might have been related to Bill's patient that he reported, who developed psoriatic type symptoms afterward. So
there was some stuff about rheumatoid arthritis, but it wasn't prevalent in the literature, but it was there. So it's clearly arthritis is happening.
Okay. Yep, Amy says correct. Sorry, go ahead.
I was just going to say, so, and I do think that Bill Devine had comments that he wanted to make. So, as you know, DO-Touch.NET from the very onset of the pandemic has been working to try to evaluate the role that a manipulative medicine approach might be able to offer in this scenario, both because of historic evidence related to the 1918 flu epidemic and so forth. Well, through the acute phases, we really didn't have a lot of people engaged in treating those patients due to numerous of issues, whether most often because of lack of access due to PPE and issues in various hospitals as to who was allowed to take part of the care of these patients and so forth. So in the end, DO-Touch.NET really had no way of contributing much to evidence associated to manipulative medicine. But the idea of the post-COVID syndrome certainly had been discussed. And in our meeting in January, Bill Devine said that, he and his group in Phoenix have been, doing work in this area and been seeing one of his residents seeing a lot of patients in the Native American population who were certainly hit hard by the acute syndrome. So that's where we began investigating, trying to put together research looking at our involvement in the post-COVID syndrome. And that's why the earlier question was raised. How many people are seeing this? And then the follow-up question is, well, how many people would be interested in participating in this type of study? So a lot of things are coming up in the chat, so I'm gonna let Jane see if she's got things to add in there. Okay.
Yes, so
Steve had a question about the 12 weeks. So, yeah, so for 12 weeks from onset of symptoms, okay, so when they would know that they had COVID. The acute phase is really the 2 to 4 weeks, all right? So that's just considered the acute phase. Generally, most people, that's it, generally after 2 weeks, but up to 4 weeks, the medical community is considering that still the acute phase. It's that 4 to 12 weeks or so that they're just sort of ongoing, but it's officially not considered a long hauler until it's 12 weeks. And again, some people don't have the symptoms at all, as Brian pointed out. I mean, they were just diagnosed, but 12 weeks later, they're ending up with migraines and loss of taste and smell. And so I think people that think they have mild cases, we don't know what's going to happen 3 months out, whether or not they're going to be the long hauler or not. Just if I could, just this last week, there was an article on the effects that it's having on the auditory system. And there seems to be a lot of ringing of the ears. And I think that's interesting because, and it's still not recognized as a symptom by WHO, but I don't know if in the news, probably, it's been a few months, the founder of Texas Roadhouse restaurant chain committed suicide, and his big complaint was the ringing in his ears, that he just couldn't stand it anymore. So I thought that was interesting that happened, and just recently it came out that more and more of that is happening, but it's still not classified as a true symptom of long haulers. But clearly it is if it's you, right?
So Jane, if I can maybe share the screen and just overview to people what we think would be necessary for us to engage in research in the post-COVID syndrome. At Convocation in March, we had some questionnaires that we asked about barriers to doing research in practice. And clearly the biggest one, the most repetitive one, had to deal with time, feeling that just don't have the time in order to make it happen in clinical practice. Well, and certainly that applies to everybody. Time is of essence in anything that we're doing. So I want to give an impression of what we feel is necessary in order to collect meaningful data on people seeking manipulative medicine care with post-COVID syndrome, so that you can give an assessment regarding time. And obviously, we can put together a great study, but if people aren't willing to participate in it, it's just going to be lost time. So I'm going to go ahead and share my screen and just give you an idea of what we have put together. All right, is everybody seeing that? Okay. Okay, so first of all, it's just a matter of defining the population that is part of the who have the symptoms. And so we have this baseline questionnaire that basically is what you see here is 3 pages. And this is something that the way we have designed it is that a person can be identified when they come in that they have this condition. They can be given a card that has a website that they go in and they can get an informed consent, and then they would have access to these questionnaires. And these questionnaires could generally be done by them on their own. So this isn't necessarily things that directly impact your clinic activities, but you need to know how this may be impacting your patient's time. So once again, this is just looking at their behaviors and their conditions prior to the onset of COVID. All right. Then the second one is then quantifying, characterizing their symptoms during their acute infection during that 2 to 4 week period of time. So we have estimated date for onset. Was it confirmed by actual test? When that could have been? Was there any indication of variants? Knowing what the variant is. And then the types of symptoms. And we've collected all of the most common factors that have been identified with the COVID-19 illness. And then if they ended up having other symptoms, we don't want to limit them to just the list that's there. Then whether they were admitted to the hospital, if they were admitted to the hospital, what type of care did they get there? If they weren't went to the hospital, did they require oxygen treatment while they were at home, and what other types of medications may they have been given? So this is a 2-page, perhaps just over 10 questions, certainly less than 15 questions to characterize their COVID symptoms. And then looking at the 4 to 12 week period. Sorry about that. Sorry. Here we go. So once again, we've looked at the symptoms. These are consistent with the symptoms of the acute infection. Did they experience them? Not at all. They had experienced it, but no more of a problem. It's currently a mild, moderate, or severe problem. So we can identify what symptoms are lingering and how big of a problem they see it. These are other symptoms that we're quantifying in the same measure. Ways in which it may be affecting their quality of life. And then just a couple of final questions in regards to any other forms of treatment, medications or psychological treatments, and then were they able to return to work? So once again, an impact on how their symptoms are affecting their daily activities. All right, so this is what they would give for the symptoms they're having when they come into your office. And then this is a questionnaire that they would fill out every couple of weeks for the first 2 months while you are working with them as a patient, and then monthly thereafter until resolution of symptoms or they withdraw from the study. So this is intended to be a longitudinal study evaluating, the impact of OMT as part of their care for dealing with these long hauler symptoms. So are there any questions about the questionnaires? If not, I'd like to open up for discussion about, is this something that the DO-Touch.NET should be continuing to develop, and are you interested in participating?
So Jed Downs has his hand up, and
Yeah, I was looking at one of the long haul citizen science group websites, and I looked at the list of the types of providers that were recommended to be in the multidisciplinary team that would be working on people with long haul symptoms, and OMM was certainly not included. I mean, they did have physiatry, but they did not have any. They did not have any OMM practitioners, and I think it's an area where the people I've seen who had issues primarily with chest pain and maybe a little bit of more difficulty with shortness of breath did get some improvement with treatment. There were also some serosal symptoms of the GI tract, and I think one of the people had some dural adhesions with increased headaches, but whether or not that was pre-existing or not, I have no idea. I'm somebody who's working somewhat part-time, and I'm able to put the time into the process, and so I'm very interested in it. And I think it's potentially an area where we do have something to offer in terms of improving the biomechanics of our patients, and maybe even being able to control some of the inflammatory conditions with good lymphatic flow and that sort of thing. So I think it's very warranted. So I'll wait to see what other people have to say.
Bill Devine wants to know when we can start.
Well, once again, what we noticed with our initial survey in acute phase is that we need to make sure we have a number of people that are willing to actively participate in the project to make sure that this is going to be result in a meaningful outcome. And so in order for us to do that, we need to make sure that we have a certain number of people, clinicians within the network that are willing to participate, and that there's a likelihood that they're going to be actively engaged with this population. So those are the two parts of that we need some information from you all in order to make sure that the time factor on everybody's part is being appropriately managed. So clearly both Jed and Bill have interest. Any other thoughts, any other concerns? One final comment. So the clinician does need to report into the database their findings, their physical exam findings, their treatment approach techniques that they use, and their assessment of how the body responded to those techniques. So each time you would see one of these patients, there would be our standard structural exam form that we have used in previous studies that we would have the clinician submit to the database. So that, between recruiting people into the study and then providing some feedback in regards to what was done and how the patient responded based off of your clinical impression. That's what we would need from the clinician.
So Jed Downs asked what type of sample size would we need for adequate power? And I responded that we haven't looked at that yet, but it's on the to-do list.
Yeah, to get any reasonable estimate generally requires having some baseline data to look at, a potential size of that effect, and then you're doing a power analysis from there. I would say that, if we could even get, 50 of our patients, I just like Dr. Altman said, I mean, this is something that requires large numbers, longitudinal data, because this is not something that's just going away for certain people. And when I looked at these clinics that are being set up to deal with this, what I am seeing is most people are being sent, to physical therapy, to physiatry, or to psychiatry, but nobody is, using, a respiratory, circulatory, neurologic model of treatment that we would be offering with a hands-on approach. So I am confident that then we have a niche to play, but we need to certainly have a large enough sample size to have any voice worth disseminating. And so that's the part that we really need to hear from DO-Touch.NET, whether people have the time and the willingness to support this type of study.
We do have a question that came up. Is this just limited to inpatient patient populations, or is it outpatient?
This is primarily an outpatient study. As Dr. Altman said, we can't identify the syndrome until they've been 12 weeks post their initial onset of symptoms. So that's why we feel that this is a more likely study design, because most of us are, our primary clinical work is in an outpatient environment.
I see from Bill Devine, he's asking whether you've considered measuring PO2 or spirometry before and after OMT and at the end of the study.
We haven't, because we don't feel that would be something that a majority of members would have access to. Certainly there could be sites that have access to that could be incorporated into the study. And I would say that certainly here in Kirksville, we would have that capability, and obviously there at Midwestern University would as well. But for the baseline component of the study, we are assuming that is not available for the majority of sites.
Jed Downs has mentioned that pulse oximetry is pretty cheap to measure.
Yeah, absolutely. I mean, $30, and I mean, it's not a bad tool to have available.
Okay. Well, I think we have gone over our time. We will certainly continue this discussion. I'll remind everyone that this webinar recording will be on the DO-Touch.NET website forums, and that's where we will continue this discussion. And watch your email for an announcement when the recording and discussion forum are available. Unfortunately, Dr. Altman needed to leave to go to another meeting, but we thank him for sharing with us about long haulers. And I thank you all. We thank you all for joining us today. Our next episode of Let's Talk About OMM Research will be a journal club led by Bill Brooks. And so we hope to see you then. Thank you so much.